residency training at the U of A before joining the Department of Pediatrics in 2006. She does both inpatient pediatrics at the Stollery Children's Hospital and community-based pediatrics at the Northeast Community Health Center, serving a lower socioeconomic population in Edmonton and Northern Alberta. Her main interest lies in immigrant and refugee health. She's a pediatric consultant for the Refugee Health Program at the East Edmonton Health Center. She also runs the social pediatrics rotation for the Pediatric Residency Program, as well as the Pediatric Residency Mentorship Program. Dr. Bukola Salami is an associate professor at the Faculty of Nursing, University of Alberta. Her research program focuses on policies and practices shaping migrants' health. She has been involved in around 50 funded research projects. She is the lead of many of them with funding from national and international agencies. She has led research projects on African immigrant child health, immigrant mental health, access to healthcare for immigrant children, African immigrant youth mental health, migration of nurses as live-in caregivers, experiences of temporary foreign workers in Alberta. Dr. Salami has around 60 published scholarly articles in peer-reviewed journals, 2 book chapters, and 8 reports. And she represents the University of Alberta on the steering committee of the Worldwide Universities Network Global Africa Group. She founded and leads an African migrant child research network of 30 scholars from 4 continents. She's involved in several community volunteer initiatives, including serving as a public member on the Council of Alberta College of Social Workers. She has a solid track record of training students. She had trained over 30 students, many of whom have received awards, including the Canadian Veneer Award and the International Development Research Center Doctoral Award. Dr. Salami herself had received several awards for research excellence and community engagement, 100 Accomplished Black Women in Canada, Sigma Theta Tau International Honor Society of Nursing Emerging Nurse Researcher of the Year Award, College and Association of Registered Nurses of Alberta Award for Nursing Excellence, and the Alberta Avenue Edmonton Top 40 Under 40. She has recently been selected as a recipient of the Sigma Theta Tau International Honor Society International Nurse Researcher Hall of Fame, the highest research award in nursing. So with that, I would like us to start this very interesting session. And thank you, Bonnie and Bukola, for your time.
Okay. Good afternoon, everyone. Thanks for taking the time to join us. Thanks, Dr. Goes, for inviting us to speak on this very important series and initiative. Before I begin, I do want to acknowledge that we're on traditional Treaty 6 territory, a traditional meeting ground for the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux, and I acknowledge my role as a settler. So the topic that Dr. Salami and I will talk about is one that's been brought to light more so now when Western societies are acknowledging the big role that social determinants of health play on health outcomes, one of those determinants being race. So we hope to present how race and racism lead to health disparities, and in particular in children. So this is a big topic, but we have narrowed it down to a few of these objectives. We would like to provide a brief overview of Canada's immigration process and numbers, demonstrate the importance of addressing social determinants of health, demonstrate how race and racial discrimination leads to health inequalities, examine the challenges and barriers to healthcare for immigrants, discuss the mental health outcomes of immigrants, discuss mental health outcomes in African immigrant youth, and identify considerations for delivering anti-racist healthcare for immigrants. And of note, we are not going to be addressing COVID in this talk, if that's what you're hoping for. So let's start with Canada's immigration. Newcomers to Canada can be broadly divided into 2 general groups, so landed immigrants and refugees. Now remember, immigrants are individuals who have chosen to leave their home country and go through a rigorous application process and arrive via different streams. On the other hand, refugees are individuals who have been forcibly displaced from their homeland, not by choice. And as you know, these numbers are worldwide are the highest they've ever been. So the percentages of 90 and 10 are fairly stable year to year with a few exceptions, more recently notably after the Haitian earthquake and when we had the influx of Syrian refugees after the Trudeau government came into power. Permanent residency status is gained once you immigrate to Canada, but they are not Canadian citizens on arrival. And refugees also gain PR status upon landing in Canada. It is important to note that temporary foreign students and temporary foreign workers are not permanent residents. This all has implications for what healthcare coverage one has, and so it is important to know when you are seeing a client how they have arrived in Canada. So for the last 2 decades, immigration numbers have been roughly between 250 to 300,000. This year we're projecting roughly 285,000, a little bit lower than anticipated given the pandemic. You can see the top 10 countries we have people immigrating from, and this big shift in numbers from non-European countries occurred in the 1980s, and this pattern continues. So as such, I do think we need to rethink how we deliver care. A popular figure that we often use is that 20% of Canada's population is made of visible minorities, but now it's actually up to 25%. And by the year 2036, this is going to be over 1/3 of our population. And the other thing that we need to shift in thinking is that people think that most newcomers end up settling in Quebec or Ontario. If you look at the first pie graph here, before 2011, 67% did settle in Quebec or Ontario. But after that, the next pie graph here, after 2011, that has come down to 57%, which means the trend is now that more newcomers are settling across Canada. And in Alberta, this is close to 1 in 5. So this actually means that we do need to be educated on the unique and challenging needs of this diverse population. So what are social determinants of health and why are they important? So social determinants of health are the conditions in which people are born, grow, live, work, and play in. In 2013, after a town hall report, the Canadian Medical Association put out this great graphic, which really highlights that 50% of what makes you healthy or not has nothing to do with your biology or your environment, but rather your social and economic environment. And another 25% is determined by your access to healthcare. Now, this is poorly taught in medical schools as the emphasis is always put on genetics and individual factors leading to disease processes. When in fact, you can see that more important than your biology or genetic makeup are things like your income, your early childhood development, gender, race, safe housing, nutritious access to nutritious foods, etc. The Canadian Medical Association identified the top 4 social determinants of health as having the most impact on health are income, access to safe housing, food security, and early childhood development. And we know that there's hundreds of papers out there that have shown the lower socioeconomic groups carry the greatest burden of illness. So social determinants of health inequity. Here I want you to look at the left-hand side of this slide. So the social determinants of health inequity are the structural processes that distribute the social determinants of health unequally in society. So this is your political, economic, cultural, social context that you live in and your social position. So keep this in mind as we move through the talk. So the WHO states that at all levels of income, health and illness follow a social gradient of socioeconomic position. So the lower the socioeconomic position, the worse the health. These disparities in social determinants of health have increased in Canada for the last 20 years, and this is most commonly in our minority and marginalized populations. The Toronto Public Health Report showed a clear link between income and health outcomes, and a newcomer health report out of Toronto showed that newcomers are more likely to live in poverty and be members of racialized groups. So let's shift to talking about race as a social determinant of health. And as you read this cartoon, keep in mind there is no biological basis for racial classification, but rather it's our attempts to organize people based on similar skin color and physical appearance. Now, if we're just to use straight dictionary definitions, race is any of the groups that humans are divided into based on physical traits regarded as common among people of shared ancestry. Racism is a belief that race is a fundamental determinant of traits and racial differences produce that produce an inherent superiority of that particular race. And discrimination is prejudice or a prejudicial outlook, action, or treatment. So this study here wanted to look at the perceptions of discrimination in health services experienced by immigrant newcomers in Ontario. They used in-depth interviews of professionals in the health services and newcomers in 5 Ontario cities. The themes that emerged were quite clear. Newcomers faced interpersonal systemic discrimination, barriers to access and care when no translation was available. They felt like they were treated like children and their appointments were rushed. They noted that their skin color, dress, language, religion, all were noted to trigger incidences of discrimination or racism. They were surprised that dental care was not covered and other gaps that they were surprised by since they were coming to a first world country. They also suggested that all newcomers receive information on how the Canadian healthcare system works, as they were quite surprised and described it as an assembly line or a factory. Racism and discrimination can be subtle, so they suggested that more cultural sensitivity training be put in place for professionals. And one newcomer also said that the findings are not new, so instead of continuing to do studies on immigrants, why doesn't the system just evolve and adapt? Now, there's been limited research that's been conducted on the effect of racial discrimination, health outcomes, and health outcomes in immigrant children. This study interviewed families who'd been in Canada for less than 10 years and interviewed them 2 years apart. They include families from 6 regions or countries in the world that they felt represented the large groups in the urban centers across Canada. Of note, the families they recruited were all from British Columbia, though. So the regions or countries that they chose or they included were Afghanistan, Iraq, Hong Kong, China, Philippines, and the Punjab region of India. Self-reported health, and in this case, parents reporting on their children's health, is becoming more popular as a global measure of health. Methodologically, this has been found to be a reliable and valid predictor of health or specific illness. So keep in mind, when they asked parents to report on their child's health status, it did include mental health, developmental, and behavioral concerns. So what they found over time is that the perceived parental and family discrimination decreased over the years, and this had a positive effect on child health. And the perceived cultural discrimination increased, and this had a negative effect on child health. Racial discrimination is often associated with maternal health, which in turn influences the mental health of the child and the overall development. And many longitudinal studies in adults have shown the same causation on health outcomes, such that discrimination precedes the negative health outcomes. Now, most of the empirical evidence on health effects of racism has focused on experiences of discrimination as a measure of racism. This 2013 study was the first Canadian estimate of the associations between race, experience of discrimination, and chronic conditions. So it was quite a large study. As you can see, it enrolled over 16,000 people. The study asked individuals to list up to 4 races they would identify themselves with, and then they grouped them into 4 broader races, so Aboriginal, Asian, Black, and White. The outcomes they looked at were having a chronic condition, such as diabetes, COPD, asthma, arthritis, cancer, etc., or an associated risk factor, such as obesity or hypertension. They found that Black and Aboriginals were more likely to report being treated with less respect. And once we control for demographic and socioeconomic covariates, such as income and education level, the discrimination was associated with nearly twice the odds of having a chronic condition and an increase in odds of major risk factors that range from anywhere between 20 to 98%. So now that we've acknowledged that race and discrimination affects health delivery and outcomes, let's look at why this is even more pronounced in immigrants and refugees. So the term healthy immigrant effect is used to describe that across a range of indicators, immigrants are generally in as good or better health than their Canadian counterparts upon arriving in Canada. This is more so in recent non-European immigrants, and we suspect this is due to pre-migration factors, which lead to self-selecting a healthier group through the immigration process, and possibly also due to healthier dietary, smoking, and drinking habits. This healthy immigrant effect does not apply to children, and it definitely does not apply to refugees, as refugees have a very different pre-migratory experiences and factors than immigrants, including the fact that they may have chronic conditions that have never been addressed or treated. This healthy immigrant effect starts to wane after 5 years for various reasons, such as economic hardships or possibly adopting unhealthy practices. It leads to worse health and proportionally higher service use than non-immigrants. So if we look at challenges and social determinants of health for all Canadians, such as economic stability, safe housing, food security, social belonging, access to healthcare, we can start to think of why these challenges would be more pronounced for a newcomer. So I've listed some here, some barriers to accessing care. A lack of medical documentation being a big one. Refugees actually often come with zero medical documentation, and you may be the first person to fully assess an individual in any comprehensive manner. Keep in mind that the immigration medical exam is very limited, and most people don't realize for a child under 12 years old, the only thing that is mandatory is that a urinalysis be checked before they come. So it is not uncommon for us to see a child with cerebral palsy, global developmental delay, seizures, fail to thrive, and all you're handed when you see them is a bottle of anticonvulsant medicine written in another language. So that's the next point, the huge language barriers including health literacy. Our Alberta Health Services literacy line is available at all AHS sites, but it has poor uptake, not only because people feel using a translator doubles or triples the time you spend with a family, but it's also because a lot of people are not aware of it. And if you're a fee-for-service doctor or other professional, it actually costs money to access. We strongly try not to suggest that you use family, friends, or children, as they come with many challenges, including information being censored, not accurately passed on. There's a worry of social stigma in the community, depending on what is disclosed. And although the children may speak better English than their parents, it is not fair to use them, given the mature subject matter, re-traumatizing them on the subjects that we're talking about, or just plain parentification of the child that happens. So next point of lack of cultural competency and sensitivity in healthcare delivery. And then unintentionally, we lose trust with our families because of the lack of cultural competency. We may say things with good intention, but it often comes across as accusing the parents of not knowing how to take care of their child. So we do have to pay attention to how we word things or what we ask. The next point about familiarity with the healthcare system. We all know that we have a very confusing health system at the best of times, and it's very hard to navigate. So think about if you're new to the country and add on the language barrier. Also keep in mind that perceptions of medicine and doctors may be very different than our Western views. You know, some families may not think controlling seizures in their child is important if they feel that is a way to get rid of their evil spirits. So keep in mind that the priorities of parents may often be very different than yours. And then obviously our complex health insurance eligibility and coverage. There's different criteria for different people. There's forms to fill out, and coverage changes without warning. The next point about mistrust of authority figures. Most newcomers are not used to having so many personal questions asked, which is quite normal in our routine history taking, especially when we do a social history. And many, especially our refugee population, may wonder if disclosing information may lead to deportation. So often I will save more sensitive history taking for the future visits when I feel like I have a rapport established with the family. There's also stigma in many cultures over certain diseases or infections, such as sickle cell disease in the African communities, or a mom not disclosing she has HIV, which may have already been unknowingly passed on to her baby. And lastly, obviously, the physical and cultural isolation of being in a foreign land. All these things put together leads to delays in accessing healthcare, and these people and families end up presenting later in their disease process. So keep in mind at any point, up to 200,000 newcomers in Canada may be uninsured or underinsured. Our interim federal health program covers refugees for 1 year, but the rules vary from province to province, and what is covered also differs. So of note, in Ontario, their coverage does not kick in until they have been there for 3 months. In Alberta, we are lucky that once the refugees land in Alberta, this coverage does kick in. But again, being uninsured or underinsured, again, leads to delays in accessing healthcare. If we apply these barriers that we just talked to a typical immigrant family who are quite high functioning and quite healthy, you can see how this all plays out. So let's use the example of Ahmed and his family. Ahmed trained as an engineer and his wife Layla as a dentist in Pakistan. they went through the application process and immigrated to Canada. They both need retraining, but they're happy to work in the food industry for now. Layla's English fluency is not as good as Ahmed's. They have 3 children. The family don't have savings to buy a house, so they rent a 2-bedroom apartment in a more affordable neighborhood. Daycare is too expensive, so Layla limits her hours and arranges shifts for when her husband is home. And her 8-year-old is happily attending school. They find that they don't have any medical benefits through work as they're considered part-time employees. Their 4-year-old has asthma, but they find that the puffers are expensive. So the other thing is they don't understand that if their bus is late, and so they get to their physician's office 25 minutes late, their appointment is canceled, and they do not know how to go about rebooking or when they should rebook. And so what ends up happening is they present to the emergency department when their child's asthma flares out. So time goes on. They continue to work at their same jobs. Frustration sets in, self-esteem affected. They find their language fluency, literacy, and even their accent affect their future job prospects. They continue to live in the same apartment, and they're finding that environmental factors are triggering their child's asthma. So the old furnace in the building, the old carpets haven't been replaced, and the smokers in the apartment. They also find that because the puffers are expensive, there's long stretches where no controller medicine, such as inhaled corticosteroid, is used for their son. And so he ends up with more severe exacerbations, especially in the winter months. So you put all this together with a lack of transportation, missed appointments, not really knowing when they're supposed to book an appointment with the doctor, and they end up presenting when the child's illness is more severe, and they end up in the emergency department, and sometimes even admitted. They're labeled as non-compliant frequent flyers by the doctors that see them, but the thing is that the underlying reasons for their non-compliance are never addressed. So as I finished putting this talk together, I remembered a survey that we had done in our own pediatric clinic many years ago. The clinic is based in the northeast quadrant of Edmonton, and we wanted to survey our patients to see what the demographics were of the people that we were serving, but also what their needs were. We found that 2/3 of the respondents were living in the second lowest average household income region in the city, and we based this on postal codes that they reported. 30% of the caregivers reported they were born outside of Canada. 1/4 of them primarily spoke a language that was not English. 1/3 had been living in Edmonton for less than 3 years, even though most had been living in Canada longer. Most of them had moved to Edmonton mainly for job opportunities. Households were of 4 or more people, and keep in mind this includes single parent households. And the other thing is the survey was offered in, I believe, 4 or 5 different languages. So what we found was that the population we were serving not only had a lower household income, but also larger family sizes and a larger portion of new Canadians than the provincial or Edmonton average. And the challenges that they identified was the lack of transportation to other appointments and also language barriers. Dr. Brocola had this study published recently where they interviewed 50 immigrant parents in Alberta, and the parents identified systemic barriers, which include long wait times or inconvenient appointment times to access. So they accessed care in walk-in clinics or emergency departments. They also noted language and cultural barriers, and also a lack of relationship with healthcare professionals. And what they meant by this is that they felt that the people that they interacted with did not take the time to get to know them or their stories, and they were just rushed through their appointments. And astutely, they also noted in terms of their financial barriers that the more expensive services such as mental health or dentistry is not covered when you have a lower paying job, and coverage that is not as good. So I'm going to now hand it over to Dr. Brocola, or Dr. Salami, sorry.
Thank you very much, Dr. Islam, for that. So I will talk about 2 studies that I have conducted relevant to the topic, which is on influence of social determinant of health, and one is on the influence of social determinant of health on the mental health of immigrants and non-immigrants in Canada. And the other study is about Black youth mental health in Canada. Next slide, please. So I just need to acknowledge my funders, includes the project was funded by PolicyWise for Children and Families. And also I'd like to acknowledge members of the research team. Next slide, please. So evidence suggests that immigrants arrive in Canada healthier than Canadian-born, which Dr. Islam has already described as the healthy immigrant effect. And one of the reasons for that is pre-migration selection factors that makes it difficult for individuals to come to Canada if they have a health problem. However, we know that the health of immigrants deteriorates after a period of time in Canada, and diverse social determinants of health have been implicated in immigrant mental health in Canada. Studies worldwide point to increased risk of mental health problems and illness in immigrant groups. Next slide, please. However, the data in Canada is quite mixed. Evidence from the most commonly used survey in Canada on health of the Canadian population is the Canadian Community Health Survey. And this survey points to a lower rate of psychiatric problems, including unipolar and bipolar among first-generation immigrants compared to Canadian-born residents. However, we've had studies, more regionalized studies that have shown a different result. So because of this, we wanted to look at another available data set from Statistics Canada, which is a national data set, the Canadian Health Measures Survey, to see what the results of that would be in terms of mental health. Next slide, please. So our study was to examine the relationship between self-perceived mental health with age, gender, migration status, time since migration, and social determinants of health factors. We also sought to examine the perspective of immigrant service providers on immigrant mental health in Alberta. The second purpose, I won't be covering it in this presentation because of the time limitation. I'll focus on the first. Next slide, please. So there were two phases. We did an analysis of data set of the Canadian Health Measures Survey, and the second phase was interview of immigrant service providers. Again, I won't be covering it, but yes, the interviews of immigrant service providers did shed light on issues related to racism and other social determinants of health contributors. Next slide, please. So we merged data collection from 3 cycles of the Canadian Health Measures Survey. We had a total of 12,160 participants that were between the age of 15 to 79 years. So this wasn't, because we are looking at a question, the question we asked was in general, how would you say your mental health is, good, fair, or poor? This question had to be asked for people that were older, 15 and above. Next slide, please. So the question was, in general, would you say your mental health is excellent, very good, good, fair, or poor? Now, just a note of caution, we were limited in terms of the question asked and the data collected. And this was the question that was asked on this survey, but I do note that sometimes the way mental health is framed in different cultural contexts is different. So, I've done a study in the past on parenting practices of African immigrants. And when I ask about mental health, it's like, there is no problem. The child is fine. But when you start asking about, as your child experienced any behavioral difficulties that you felt were beyond your control as a parent, have you experienced, how well does your child get along with other people? Then you start actually getting more insight into mental health issues. But again, we are limited to this question that was asked in the survey. Next slide. So here are the covariates that we looked at: immigration status, time since migration, age, sex, income, sense of community belonging, education, and employment. Next slide, please. So we applied weight to account for missing variables and non-response bias, migration status and time since migration. We actually did the analysis, did 2 different analyses, but the data that we are presenting is based on time since migration, but I'll also tell you what the analysis when we put in immigration status was. We analyzed the data using SAS 9.4. Next slide, please. So this is the data that we have on demographic data. And one thing to note in this data is the difference between immigrants and non-immigrants in terms of their income level. So immigrants tend to have an income that is $10,000 less than non-immigrants in Canada. But when you look at their educational variables, it seems immigrants tend to have more education than non-immigrants in Canada, which is consistent with national data that on average, immigrants tend to be more educated than non-immigrants in Canada, but they also tend to get paid less than non-immigrants in Canada. So of course, there are several factors that contribute to this. You can shed light on the fact that maybe it's credential assessment that contributes to it. But people have also argued about systemic racism within the system in terms of employment of immigrants and their treatment within the employment sector that may contribute to this. And we know that all this income has a strong influence on health outcomes in Canada. There's something, in light of, especially in light of the COVID-19, when I was a master's student that I once heard, which is called the cappuccino effect. When you look at the healthcare sector, you see more immigrants at the bottom, more Black people at the bottom of the hierarchy, and more Caucasian people at the top of the hierarchy. And people say, healthcare field is like a cappuccino. It's Black underneath and it's white on top, and it requires stirring up. And this is, one of the things that you see in terms of, differences in income levels between people of different races. Next slide, please. So our result, there was no statistical difference in our results when we looked at immigrants and non-immigrants on self-perceived mental health. That's after we've adjusted for age, sex, income, sense of belonging, education, and employment. However, individuals who had lived in Canada for less than 5 years reported better mental health status than Canadians. So what we saw is that in the first 5 years, people were reporting that they had better mental health based on the question asked than Canadian-born population. But then in 6 to 10 years, people were reporting much worse mental health status than Canadian population. Predictors of better mental health included higher income, older age, sense of community belonging, and being employed. And we were in the lab a few times, and no matter how much we manipulated the data, the two strongest influence on mental health were higher income and sense of community belonging. When people feel like they belong to a community, then their mental health is more likely to be better. And when people have a higher income, then they're more likely to report their mental health as better. Next slide, please. So this is, information about the results. So when you look at sense of community belonging, you'll see that very strong versus very weak, that people with very weak sense of community belonging are around 4 times less likely to report their mental health as good, as opposed to very strong sense of community belonging. Next slide, please. So I'll move now to talk about the project that I just did on a youth-led participatory action research project on mental health of African, Black, and Caribbean youth in Alberta. Next slide. This is all data. In 2011, in 2016, there were, and sorry, I have not updated this. In 2016, there were around 1.2 million Black people in Canada. Alberta has one of the fastest growing population of Black people in Canada, and also one of the fastest growing population. Not one of, it has the fastest growing population between 2011 and 2016 of Black people, and also immigrants in Canada. Evidence suggests that Black youths have a higher rate of mental health problems than the general Canadian population. And despite this, we found no study that has provided basis for action from African, Black, and Caribbean youths' mental health. And our project sought to address this gap. Next slide, please. So we wanted to look at what are the mental health needs of Black African and Caribbean youth in Alberta. What are the barriers to access and mental health services of this population? What are culturally relevant and effective approaches to increasing access and uptake of mental health support? And what potential exists to mobilize knowledge? Next slide, please. We interviewed 30 Black youths of African, Black, and Caribbean descent, between the age of 16 to 30. And we also held a series of conversation cafe for around 100 Black youth. It was an open forum for stimulating dialogue on relevant societal issues. We combined smaller group breakout sessions with larger group breakout session. We had brought 4 conversation cafe. The first conversation cafe, so we had an advisory committee of Black youths that advised us through the project. There were 10 of them, and 6 of those people were involved, collected our data, and they also led the conversation cafes. And based on the emerging data from the interviews, the Black youths decided what topics we wanted to focus on. So the first topic they wanted is, because it was September and youths were coming back to school, they wanted just a general topic about mental health. The next topic that they wanted to talk about was intergenerational relationships. So they wanted, how can I better deal and work with my parents? They also wanted a session on intersectionality. And within the section on intersectionality, they acknowledged some of the experiences that Black LGBTQ communities face in terms of they come into the Black community, they face homophobia, and they come into the LGBT community, they face racism within the community. So they wanted a space where they can discuss. So we had 3 members of a panel, and 2 of those were from LGBTQ. One was Black, one was non-Black, and then we had 1 other speaker that wasn't from the LGBT community on the panel. And then they also wanted one that talks about policy and how to move policy forward on mental health. Next slide, please. So this were the youths. We held a stakeholder engagement there at the end of our project, and the youths did the presentations to the stakeholders. So this was done during the final presentation of our results. Next slide, please. So some of the factors impacting youth mental health, the 2 strongest factors that they discussed was racism and also intergenerational relationships. So people talked about the fact that they grew up with internalized anti-Blackness and how anti-Black racism influenced them, on having to go into a space and always having to demonstrate that you're not there to harm anyone, especially for Black male youths. They also talked about the academic expectations. Many of those that we interviewed were university or college students and having to balance those worlds. And they also talked about cultural expectations. So the cultural expectation that, if you're Black, you can't have a mental health problem. Mental health problem is for Caucasian people. So when you tell people, they don't really take you seriously when you say you're dealing with a mental health challenge. Next slide, please. Other issues were openness about mental health, a sense of community. So when they have a sense of community and feel like they belong to a community, then they feel supported. And religion and spirituality has also has an influence. In terms of spirituality, they tend to discuss positive influence of spirituality. So if I have a problem, I pray and all those. And in terms of quite mixed. So some discuss, yes, religion is supportive, but some discuss it could also create, sometimes they feel othered based on, maybe their other social locations, including, being a member of the LGBTQ community. Next slide, please. Barriers to accessing mental health include cost of mental health services that they are often unable to access. They feel like the geographical barriers, distance from mental health locations, that a lot of mental health services are often located in areas that are not for Black people, or that Black people do not often feel safe in spaces where mental health services are being provided. And they also talked a lot about the lack of Black demographic representation in mental health service delivery. So one of them talked about, maybe she goes to a white counselor and tells the person, I'm experiencing racism. and then the person is like, oh yeah, you're experiencing racism, that's true, and then merely just change the topic to something else. I don't feel comfortable helping the patient or the client to really deal with some of the racist issues that they're experiencing. Lack of knowledge on mental health services was also discussed. Next slide, please. Sorry, Dr. Islam. And also stigma and judgmentalism, intergenerational gaps. So as I said, the two strongest things they discussed was the gaps, in terms of their parents not understanding them, or even sometimes the parents also have dealt with mental health crisis in the past that have been unresolved, and because the parents have not been able to resolve their own mental health challenges, they cannot effectively deal with their children's mental health challenges. And the culture of independence. Next slide, please. Some of the strategies they used in terms of coping includes peer support, religious teaching and practices, including prayer, and often sometimes also negative strategies such as self-imposed isolation. And they also talked about the use of music in coping with some of their challenges. Next slide. So the findings of this has several implications. I'm not sure if I have a slide after this. Oh, okay. The findings of this have several implications, and some of the implication includes the need to really consider the social determinant of health, including mental health, when delivering services. The need to pay attention to race and racism as a social determinant of health for Black youth, and also considering anti-Black racism as an essential competence, and also the need to capitalize on the agency and strengths of Black youth. Thank you, Dr. Islam.
Okay, thanks, Bakoa. So the key points we want that we want you to take home with you is that to recognize how implicit social determinants of health are in your patient's overall health, especially income and race. Know that racism increases the health disparities already experienced by immigrant children. Recognize your own biases and assumptions which lead to discrimination in healthcare delivery. Acknowledge that certain patients will require more of your time, including using appropriate translation services. And then know that advocating for better coverage and access to care for our most vulnerable will help with the healthcare system, will decrease the cost of the healthcare system. We're advocating for better coverage and access to care for our most vulnerable will cost our healthcare system less money in the long run. And what I mean by this is there's an example that in 2012, the federal government made sweeping cuts to the interim federal health program. And there were Canada-wide protests by doctors, including here in Edmonton, to put pressure on the government to reinstate some coverage and to educate people that cutting coverage for our refugees would actually cost our healthcare system more money. And so this pressure did lead to a temporary health program to be reinstated to provide some coverage, but it wasn't until the new federal government came in that the actual IFH program was reinstated. So looking forward, we would want you to think about and understand how underfunding of services such as early childhood development, mental health, in-school supports, community partners, etc., affects the families you serve, and why more so in our immigrant population. Income-related health inequalities persist or widen as children age, and we need our governments to examine ways to improve the social and economic circumstances for all Canadians. And one thing that a lot of people are not aware of is that Edmonton is the only major Canadian city without a dedicated newcomer clinic. We do have a refugee health program out of the East Edmonton Health Centre, but that is only limited to our government-assisted refugees. And I strongly feel that we do need more teaching and integration of social determinants of health, health inequity, immigration policies into the medical school and residency curriculum. And a lot of this is already starting to be done. Dr. Goes's physicianship course that runs the first 2 years of medical school is addressing some of these topics. And that's the end of our talk. And so I think we'll open it up. Dr. Goes?